carpal tunnel release, open or endoscopic? So almost we all encounter carpal tunnel in our practice. Many of us do open surgeries. I have done earlier open, but now I have moved on to endoscopic. So carpal tunnel syndrome is the most common nerve entrapment uh, at the wrist level, which causes entrapment at the wrist and leads to hyposthesia on the palmar aspect of in this region and on the dorsum on this region. So patient usually come with the symptoms of tingling numbness in this area. The first formal description of this carpal tunnel release was given by Learmonth, and the entity itself was described by Sir James Paget much earlier. So, when we consider carpal tunnel release, the release is because to prevent the patient's median nerve symptoms. But while doing so, we need to take care of or watch out for the recurrent motor branch of the median nerve or also palmar cutaneous branch of the median nerve. And usually whenever you do any surgery in this region, so you need to be on the ulnar aspect in this area. Usually the line corresponds with the fourth and that's ring finger. So there have been various incisions described by various scientists about the carpal tunnel release different fashions. So over a period of time, from this open region, gradually we have progressed, or like I have progressed from open to the endoscopic carpal tunnel release. The first formal description of the endoscopic carpal tunnel release was given in 1989 by these three gentlemen, Dr. Chow, Dr. Okutsu, and Aji. So they tried this endoscopically. So they decided why endoscopic release, because it gives faster rehabilitation. As a daycare procedure, it can be done. It is very cost effective, can be done under local anesthesia. So we can test our patient after the surgery. It saves operative time. We can tackle or save the sensory branch of median nerve. There is a small non-oblique scar. Proximal release, proximal to the carpal tunnel is ensured, and it preserves the natural anatomy. So what is that natural anatomy? So there is one soft tissue band called as interthinner soft tissue band. Dr. James Chow had studied this, and he has said that if you are doing open, then you need to cut this soft tissue band and go and dissect the carpal tunnel. And he has also done the histopathological study about the same, and same he has published. So that's the reason why we should not cut this interthinner soft tissue band and go for the endoscopic release. So there is these various instruments which are being used. So these are the various knives. Then this is most important, that's a dura elevator, various dilators, and other instruments along with that scope. So I'll just show a small video technique. So sorry for the sound. So you mark the carpal tunnel boundaries. So that's the sound of my wife actually. So I wanted everyone to hear. So she has given the voiceover for this video. So once you do the, you mark the carpal tunnel boundaries around 1.5 centimeter above the proximal carpal tunnel crease, inject the local saline. So local is, local anesthesia, 0.25% sensorican, just into the subcutaneous area. I don't inject a local anesthesia into the carpal ligament itself. Then there is a skin incision taken at that position. Skin is retracted. Then there is a antebrachial fascia. This is dissected very carefully if it's a superficial dissection. Once it is done, so you can see once you cut it, the fascia transversely, then later on with the help of this dura, you can check the movement of dura. You feel get sudden give way. So that means you have entered into the carpal tunnel. Then my left hand index finger is checking where is my dura. Then with the help of serial dilators, the dilatation of the carpal tunnel is done. This is a commercially available carpal tunnel relief kit which has got a slotted trocar and cannula. So we do that. Once that is done, then in that same slotted cannula, we put scope and check the carpal tunnel. we can visualize. So carpal tunnel is above the, so scope is facing the palmar aspect, palmar surface. So we are under the carpal tunnel ligament. So if any fluid or blood, then it can be cleaned with these cotton tips, which are already plasma sterilized, or we do get disposable ones as well. So this is a knife which is available in that kit. So it helps in cutting that carpal tunnel. So that's the video of the through the scope. You can check that this is the carpal tunnel. I have checked the carpal tunnel. Then the knife will come. And then gradually knife is going and we are cutting the ligament. So again you can reassess if the adequate release has been done or not. Then if some fibers are left, those also can be cut. Then similarly, we cut or release the proximal fascia also in the same manner. Then once it is done, we check the patient's movement. And if everything is okay, then that completes the procedure. Now, after that, now I have stopped doing single portal. Now I have been doing double portal. So double portal, this is the, I have got the instrument for that. So this is the palmar arch. So just before that, you exit the portal, pass your slotted cannula. This cannula is very small. It's 4.5 mm diameter. The blue ones, the commercially available, which I used to use earlier, was very bigger one, like almost 5.5 to 6 mm diameter. So there are various knives are used. The first knife which was like a pointed knife. After that, the second knife, which is a reverse cutting knife. So with that, we'll cut the carpal tunnel in a retrograde fashion. It's cutting the carpal tunnel, now carpal ligament. So now scope is from the patient's proximal end, and the cutting instrument is going from the distal end. So that's the proximal, the reverse cutting knife is cutting the, then you can see the muscles or band above the cut carpal tunnel ligament. Now there is third one knife available. So that's gives, that protects the superior surface but cuts on the front. So that this is that third knife. So it is cutting on the, as we progress advanced ahead, it keeps on cutting the carpal ligament. So usually skin is closed with 3-0-ethylone and patients are discharged within 1 hour. 10th day post suture removal is done. So the pros being revision surgery, if any required in future, can be done by open way. Local gives additional advantage. We can, if the patient is getting a lot of pain during the insertion of slotted trocar and cannula, so we know that there is something problem, so we can convert into the open. There is no scar tenderness. Patient can return to work early. So the cons being tight tunnel needs to be opened. Everyone is not skilled to do this surgery. There is a little long learning curve. Setup is costly, and availability of this kit, now it is being available, and it is very difficult to do revision cases. So there are various publications, they have shown that both have got the similar results in terms of functional status and return to work early. But patients are like sometimes, now this is this one more article. So sometimes patients, they do demand endoscopic surgeries, but still the literature says that endoscopic is still done by 20% of patients and open in 34 patients, and mini open is done in 46 of patients. So literature says that both techniques are well tolerated with no difference in the functional course and no difference with the patient's pain course, but the patient's acceptance is little higher and overall satisfaction is little higher with the endoscopic procedure. So this Aggie, McCall and North, which gave guidelines almost 30-40 years back, that for endoscopic, better to know the anatomy, never overcommit the procedure, ascertain that the equipment is working properly. If scope insertion is obstructed, convert into the single incision. If blade assembly is in the carpal tunnel, make sure that it is in the carpal tunnel and not in the Guyon's canal. If clear view is not obtained, ready for the open procedure. Do not explore carpal tunnel with the scope, and if view is not normal, about the procedure. and stay always in line with the ring finger. And when in doubt, get out. So thank you very much.